infectious disease roundtable this morning, and we'd like to welcome you, Dr. Mehreen Arshad. She will be speaking to you about urinary tract infections and has other information regarding infectious disease that she will be sharing with you. So without further ado, I'd like to introduce you to Dr. Arshad. Thank you very much. I will now make you a presenter, Dr. Arshad.
Thank you. All right, well, welcome everyone, and thank you for taking the time out to attend this session. So I will be talking about urinary tract infections and just very briefly go over their treatment, some, think about prophylaxis and then recurrent infections as well. So I don't have any disclosures. The objectives of my talk, I'm going to keep everything very brief, but please feel free to reach out to me either in the question and answer session or via email later on. And so really we're just going to talk very briefly about the microbiology of UTI, discuss the appropriate use of antibiotics during management of UTI, talk about some of the data that me and my research team has pulled about the increasing resistance rates in children in Chicago, and look at the management of UTI in a febrile child, and then also management of recurrent UTI. All right, so as you all know, most common, and again, this is for neonatal UTI, but this is true for pediatric older children as well. The most common organisms that cause UTI are gram-negative rods, and those include E. coli. That's really the major organism, about anywhere from 40 to 70 to 72% of E. coli of UTI in the neonatal period is caused by E. coli. And then there are others such as Klebsiella. Gram-positives, some of the gram-positives such as Enterococcus and Staph aureus can also cause infections, but by and large, it's really the gram-negatives that cause UTI in the neonatal population and also in the older pediatric population. So this study basically looked at both outpatient and inpatient. And as you can see, in the epidemiology of the organisms causing UTI is pretty much common, pretty much the same across the board. So in antibiotics, a lot of antibiotics are used to treat UTI. If you look at the number of antibiotics that are prescribed, UTI is among along with acute otitis media is probably one of the most common diagnoses that for which antibiotics are prescribed. So this was a study that was done recently in Pennsylvania at Hershey's, and they looked at the inappropriate use of antibiotics for children who were diagnosed with a UTI. And the inappropriate antibiotics could be either because of the culture, the UAN culture were not positive and patients were still treated, or they used the wrong antibiotic or for the wrong duration. And so what they basically showed was that amoxicillin and fluoroquinolones were the most common antibiotics that were used inappropriately. And amoxicillin, I'm guessing it was in the discussion, they basically talked about the fact that about 50% of E. coli are resistant to amoxicillin, and so sometimes that is not the best drug. And so you really need to follow the culture and sensitivity and alter your the management according to that. Fluoroquinolones, I think, are very overused in this population and should not really be used unless there is an absolute need to do so. And then this table on the right-hand side looked at the appropriate versus the appropriate antibiotics that were used, or the appropriate dose, and then the appropriate dose and the duration. And the appropriate dose was probably used more frequently, but still there's plenty of room for improvement. And then the appropriate dose and duration was sort of, in pyelonephritis was only 50% or less than 50% really. So I think just sort of understanding how, and this study was done in the ER, so not exactly in the outpatient setting, but still a lot of these children did not end up getting admitted. So by and large, these children were in the community. And so just understanding what constitutes a real UTI and how and what kind of treatment is appropriate is really important. So this is an ongoing study, so we haven't really published it. We're hoping to actually pull data from other institutions across the country as well. But this is data pulled from Lurie Children's Hospital over the last 10 years. And so it's from 2010 to 2019. And we looked at the rates of resistance among uropathogens, so bacteria that were isolated from urine samples in our lab. And over time, you can see this is inpatient and an outpatient, and the patterns are pretty similar. And you can sort of see that over time, the resistance rate for Bactrim, it has been pretty stable. But for the beta-lactam, the beta-lactams, such as ampicillin sulbactam, ceftriaxone, cefepime, and even levofloxacin, they've gone from like near 0%, even back in like 2013, 2014, to up to like 10%. And this is, again, as I said, similar across the inpatient and outpatient setting. I think what's sort of really concerning to us, to me as a pediatric infectious disease physician, is that you would think that infants or neonates are sort of protected because overuse of antibiotics tends to accumulate, or there's a cumulative effect over life. But unfortunately, I think what's happening is that there are just a higher burden of these resistant organisms in the community. Perhaps mothers are colonized, transmitting to their babies. But what you can see over here is that the line in green, which is the neonatal population, line in yellow is the less than 1 population, and then all ages is less than 18. And there, the resistance pattern, both for ampicillin sulbactam, ceftriaxone, even cefepime, they pretty much track along the older age group as well. And so I think just again, being careful being careful in terms of not over-prescribing antibiotics is just becoming so much more important given these increases in resistance across the country. And so just talking about diagnostic test, this table essentially is from the AAP guidelines from 2011. And they just looked at the sensitivity and specificity. So together, leukocyte esterase and nitrite test on their own, may not be very, very sensitive, but when you combine the two, they have about a 93% sensitivity, and the specificity is still sort of around 70%. What I think the thing that I just wanted to point out is that remember that the nitrites the nitrite test becomes positive, and the dietary nitrates from the uropathogens are converted by uropathogens into nitrites, and that takes about approximately 4 hours. So sometimes in children, especially in babies who are not potty trained and who are continuously sort of peeing, that test may not actually be positive. And so I think you just want to be careful in the right clinical setting to think about UTI, even if there is a negative nitrite test. And some organisms don't. Most diseases are gram-negative uropathogens that convert the nitrate to nitrite. And so if it's a gram-positive infection, you won't actually get that positive. So I'm sorry, this is kind of busy and small, but really this is the algorithm that we have put together at Lurie Children for our ER. And management of UTIs in the emergency department. And so I thought I would share this with you. I'll just go over this briefly. So again, you want to make sure that you're doing, when you're testing for, or if a UTI is on the differential, make sure that you send both a urine analysis as well as a urine culture. Treating a patient with, one or the other is kind of, it's a little bit difficult, and probably is one of the more common reasons for over treatment. And so again, if UA is negative, then you sort of go down, and the algorithm over there, if there's no evidence of inflammation, it's not likely to be a UTI. If you have an afebrile and well-appearing child, and there's concern for pyelonephritis, either based on symptoms, you have flank pain, or it's just a young child, a baby, where it's going to be difficult to distinguish pyelonephritis from cystitis. If you have, if there is a concern, if there's not a concern for pyelonephritis, then we recommend starting PO-Keflex empirically, and use that for 7 days as long as the culture results show that that's appropriate. If there is concern for pyelonephritis, then we recommend treating for up to 10 days. When patients are discharged from home, again, just make sure that the urine cultures are followed up and narrow antibiotics as appropriate. So as I said, ampicillin, 50% of E. coli in this country are resistant to ampicillin, but 50% are not. And so, you can narrow from Keflex to the first generation cephalosporin to ampicillin. That should really be done. And then, so we talked about urine analysis, but also culture. So typically we basically count a positive culture as greater than 50,000 CFUs of a single organism via a cat specimen, or if you have, and plus that there's an abnormal UA or dip. In some cases, especially in the younger age group, in babies, I think we've been a little bit more conservative in treating them, and depending on the clinical scenario, if there is a single organism of even like 10,000 to 50,000, I would consider that positive. Again, sort of making sure that the UA is sent and that there's at least some evidence of inflammation on the UA, which could either be a leukocyte esterase positive or nitrite being positive, or white blood cells being positive. And again, if any of this, one important thing, if you have a symptomatic teen, do consider both GC and chlamydia as cause of the UTI as well. And then, according to the AAP guidelines, if it's a first-time febrile UTI in a less than 2-year-old, then it is recommended to get a renal bladder ultrasound. But as you'll know, VCUG are not recommended after the first UTI. On this particular side of the algorithm, I'm not going to go into so much, but basically, if you have if you have a febrile, ill-appearing child, and you want to go into, and you end up going to the inpatient route, you can either start IV ceftriaxone or start PO Keflex and just sort of monitor them depending on how they do. All right. So in the outpatient treatment, we talked briefly about empiric therapy. So these are sort of the doses for cephalexin. Or if there is penicillin or cephalexin allergy, you can try, or you can prescribe Bactrim as well. For pyelonephritis, essentially the same, but for a longer duration. And then once culture is, the culture results come back, if there is sensitivity to amoxicillin, and then, or, depending on sensitivity versus resistance, these are the typical doses that we would recommend. And also just remember, there's no need to do a follow-up urine culture or even surveillance cultures after that first episode or after any episode of UTI. All right, so I'm going to now go into recurrent UTIs. So consider this particular case. I mean, I'm sure that this is something that you will see very commonly. So this is a 9-year-old who is healthy, otherwise healthy girl, and she has a history, so she doesn't have any urologic abnormality per se, and she has a history of these recurrent UTIs where she gets 3 episodes and lost 8 months. All of them are E. coli, so they're the same, pretty much the same organism. Main symptoms of UTI are lower abdominal pain, nausea, dysuria, and usually she is not febrile with these episodes. So the question that you might ask yourself are, would you start her on prophylaxis? And if you did, how long would you use the prophylaxis for? And are there any downsides of the prophylaxis? So let's just go over sort of the pathogenesis of recurrent UTI. So there are a number of different factors that are involved in, in the recurrence of UTI in specific children. And so you can have bowel and bladder dysfunction that might be because of either functional constipation or lower urinary tract symptoms, which are basically like burning or children who are not sort of emptying their bladder appropriately. When there is urinary retention because of bowel and bladder dysfunction, that enhances the bacterial growth and adhesion of bacteria to the bladder wall epithelium. Urine is an excellent medium, an excellent growth medium for bacteria. So any sort of retained urine over time will increase the risk of recurrent infections as well. And then you can have VUR, especially high-grade VUR. So 1 to 3 is typically not associated with recurrent UTI, or the risk of recurrence is low. But high-grade reflux, that's 4 to 5, is a major risk factor for recurrent UTI. And then you can also be colonized with some bacteria, either within the gut or within the vaginal area in girls. And some uropathogens are basically inherently able to cause disease. And how they cause disease, and what happens from a child being colonized to them actually getting infected with the bacteria is very complex, and I don't think we don't totally understand it. But it's suffice to say that if a child is colonized by UTI-causing bacteria, uropathogens, their risk of infection or their risk of recurrence also then increases. And so urinary stasis is actually one of the most common causes of bladder dysfunction overall. It's one of the most common causes of recurrent UTI, especially in otherwise healthy in children who don't have an anatomical abnormality. So up to 1/3 of those with constipation would also have recurrent UTI. And functional constipation basically causes this urinary stasis because of compression in the bladder and elongation of the urethra, and that then reduces the urinary flow and promotes pathogen adherence. Children with functional constipation also have been found to have renal pelvic dilations, even in the absence of anatomical abnormalities or infections. So really that increased pressure in the bladder can then actually cause perhaps backflow into the kidneys as well. And voiding dysfunction, including urinary incontinence, post-void residual urine, then results in a higher rate of recurrent UTIs, especially in girls. This particular study basically looked at, this was a retrospective study that looked at more than 600 children with UTI, and they showed that children who had high grade 4 and 5 VUR had an increased risk of recurrent UTI, but grades 1 to 3 were not. And this is sort of just down here. If you look at the odds ratio, those who had grade 1 to 3 were associated. We did not have recurrence of disease, whereas those that did that had higher VUR, higher grade VUR did have recurrence of disease. So this is one of several studies that have shown this, and I think that that's sort of in the ID/urology world this is pretty well accepted. I will also just mention the RIVUR trial because this is one of sort of the key trials that have come out in the recent years, looking at trying to answer this question about whether or not or when to start prophylaxis and whether or not children should be on prophylaxis. Children with first-time UTI should be on prophylaxis. And so this RIVUR trial looked at 600 children, and the children were randomized to either receive trimethoprim sulfamethoxazole or placebo for 2 years. And they did show an approximate 50% reduction in recurrent UTI, irrespective of the number of the severity of VUR, and the number needed to treat was 8. So you needed to treat 8 patients in order to prevent 1 episode of UTI. The problem with all of this, and the reason, at least in my world, in the ID world, we are wary of the interpretations of this data, is that 63% of recurrences in the prophylaxis groups, those that were getting Bactrim, were due to trimethoprim-resistant E. coli. And that's really concerning given the rapid rise of antimicrobial resistance in the recent years and the data that I showed you from the Chicago area. And so I think that's one of the reasons why we have held back from using prophylaxis if there isn't a history of recurrent UTI or there is an anatomical reason, because I think the downsides of using prophylaxis are a lot higher than the benefit that somebody might get. And again, one of the key things that this study did not address was the reduction in the incidence of renal scarring. Because traditionally, one of the biggest arguments in favor of using prophylaxis was to prevent recurrent UTI, which may then cause cause renal scarring, but that was not shown in this particular study. And so just sort of briefly, what are some of the other measures that one that there are, I guess I should say that they're under study right now, but there is some anecdotal evidence that might work. Even the studies are not great. But one of them is probiotics, and usually probiotics, the way they work is that they produce these antimicrobial products such as hydrogen peroxide, and they sort of they alter the microbiome of the gut in the child. They also inhibit the attachment of the uropathogens to the gut epithelium, and so basically they essentially crowd out the uropathogens and actively inhibit their colonization. And so by reduction in the burden of uropathogens in the gut and the vaginal area, the risk of recurrent UTI is also thought to go down. There are only a couple of studies. There are a number of studies, but these are the couple that I wanted to just mention. Is that there's this one study that looked at 120 children. They looked at lactobacillus or trimethoprim in their patients, and they basically showed that the rates of recurrent UTI were similar in the two groups. And then in a follow-up trial, 128 infants that were diagnosed with primary VUR. So this was low-grade VUR, not grade 4 and 5. They were randomized to receive either the probiotic lactobacillus or trimethoprim. And again, the rates of recurrent UTI in the probiotic and antibiotic prophylaxis groups were not statistically different. And then this was another study that looked at 191 infants, and these infants had acute pyelo with otherwise normal anatomy, and they looked at prophylaxis with lactobacillus that led to an 8.2% incidence of recurrent UTI in a 6-month follow-up, and that was similar to the 10% rate in antibiotic and significantly lower than the 20.6% rate with no prophylaxis at all. I think this just sort of goes to show that if there is, perhaps probiotics have some value, but this really needs to be studied better. Cranberry juice is another thing that people have talked about. The cranberry extract is supposed to inhibit, again, the adherence of these uropathogens to the bladder epithelium. The problem with most of these studies are that they are at a very small sample size, and the formulation of cranberry juice and extracts is sort of all over the place. So just sort of briefly, this is my last slide, I think. So I'm just going to leave this over here. These are a couple of studies that were there. Again, not very well studied and very small groups, very small studies. So just the last last slide that I wanted to go over in terms of what would you, if you have a diagnosis of recurrent UTI, I think you want to screen for lower urinary tract symptoms, and those could be either, as I said, burning on peeing and just sort of frequent going to the bathroom frequently, and some of that just has to do with hydration, timed waiting, pelvic exercises, and stuff like that. And we do recommend referral to ped urology at that point. We also want to screen out for bowel bladder dysfunction, constipation, rule out VUR. If there's no bowel and bladder dysfunction or VUR, and there's really no evidence for prophylactic antibiotics, then you could potentially consider probiotics. And maybe if there is a quality of life is an issue, then you might consider prophylaxis with nitrofurantoin. But really, I think just sort of better, talking to parents and sort of managing expectations is more important. In grade 1 to 3 VUR, again, not much evidence for prophylactic antibiotics. Can consider nitrofurantoin if the recurrence is sort of hindering the quality of life. And then in grade 4 to 5, I think there is some evidence for prophylaxis with either trimethoprim sulfa or nitrofurantoin, and then also sort of one referral to urology, obviously, and then considering surgical intervention. So these are the prophylactic doses if recommended, and then I will end with that. Thank you.
Thank you, Dr. Arshad. That was wonderful information. If anybody has any questions, please feel free to type them in the question box. I do actually have a couple questions. You had mentioned the probiotics. I wanted to know if there was actually a preferred probiotic that you have found success with better than another one?
Yeah, thank you for asking that. So I did not mention this, but we are actually conducting a study using Saccharomyces boulardii. So Saccharomyces boulardii, the trade name for that is Fluorostor, but you can find it as sort of the generic Saccharomyces boulardii as well. That's actually it's a yeast probiotic. So one, it doesn't get affected by any antibiotic that a child may be on at the same time, and also there's a lot more evidence. We are hoping we're actually starting to enroll hopefully next month in this trial. But there is a lot of data from patients who have diarrhea and C. diff, and the Saccharomyces actually tends to modulates the microbiome very effectively. And so, and personally, again, anecdotally, we've had a lot of success using Saccharomyces boulardii. So I actually think that despite the fact that we don't have published evidence for it, I actually find it to work much better than lactobacillus.
Okay, thank you. And then one other question: have you noticed an increase in urinary tract infections over the past few years? Or
I was trying. So the reason that we did the study that I pulled, that I showed you, was because when I finished my residency in 2015 in North Carolina, and then I moved here to Chicago in 2018. And honestly, or not 30, I finished my fellowship in 2015. And honestly, I feel like I see a lot more UTIs, especially children being admitted into the hospital with UTI over here than I ever did in North Carolina. And again, that's the reason why we started to collect the data, because I don't know if the incidence of UTI has gone up, but I think the incidence of recurrent or the incidence of antibiotic resistance has definitely gone up. And I think we're seeing more and more children needing to get admitted into the hospital for IV antibiotics because of that increase in resistance. And that's something that's shown and that's been seen in adult population as well. So I'm not surprised that we're seeing it too.
I do think we do have one other question from Dr. Adil. If you, Dr. Adil, if you would like to unmute yourself, you can feel free to ask Dr. Arshad, or I can unmute you.
Yeah, hi. I just want to know if I can get a copy of the slide on the specificity of urinalysis.
The algorithm?
Yeah.
Yeah. Are you comfortable in sharing that, Dr. Arshad? Can we? We can send that out. Okay. Thank you, Dr. Adil. Is there anything else that another question?
No,
okay.
thanks.
All right, great. Thank you. Yeah, we'll be happy to get that algorithm out. Are there any other questions from anybody that's watching right now? We have just a couple more minutes. If not, I just wanted to thank Dr. Arshad for her excellent information on the urinary tract infections, and she is available. You can reach her through her email, or the Lurie Epic in basket as well. And also, just as a reminder, we do have the Lurie MD line, which is a 24/7 phone line where you are able to have a physician-to-physician consultation within 30 minutes or by the end of the business day, whichever is more convenient. Also, lastly, we have a couple other presentations today, one at noon, one at 3, and one at 5. Please feel free to check your email, and you can register for one of those links for later in the day. We'll have one on Kawasaki disease, that's at 5 o'clock. HIV infections is at 3, and common questions for mom and baby is at noon. So thank you very much, everybody, for attending today. And this session was recorded. You will have access to a recording most likely by the end of the week. Thank you all for attending, and we hope to catch you at one of our later ones today. That concludes our webinar for today.
Thank you. Bye.